specific church. You know, we stay in the back because the offering plate only comes once back there. So before we start, I would like to call up Ms. Fahina Pasi to say our prayer. And she's going to say in Tongan, so you can come up, so she can complain about Samoan in her prayer. We won't know what she's saying.
Taulot, tamai ko matong ko whanau mapuno te hoatan ka at whamalo mo whawhitaki he a whiona ki ngā tāpua katoa pēu ko whakmagitek mautoro. Mau whamalo fo ki tamai ko hinga ko ki nautoro. Nanau, fotu tu ngai meat. Whamalo fo ki ha. O whewhine ko nia, ko hinga ko he taimilahi ko ne tuku. Ke whakatahai mai mautoro ki he watani. Ke hawaini ke mawhea ko aki. Ma watu ha ofa, whawhetai lahi ki ha whiona, pa ma whaingai mea ni he wafo sisu kalaisi. Amen.
Good morning, everyone. All right, let's try it again. Good morning, everyone. Good morning. All right, on. Okay, let's give ourselves a round of applause because we made it through the night and we're here. All right, I have the distinct honor of facilitating my last plenary, which I thought I was fired yesterday if some of you were in the audience, but I guess I was rehired as soon as I was fired. So it gives me the great honor of presenting introducing two of our presenters for today, titled COFA Migrant Health and Health Policy. And I could say definitely with two of these presenters, I've learned a lot. And as a Samoan who was born and raised from the Big Island of San Diego, and a true and hard advocate for our Pacific Islander communities, I am blessed to know these folks because I need to educate myself on all of our communities. You know, we tend to say, you know, like Polynesian Festival and so on, but we have to inform folks that, you know, we leave out two of our other cousin regions. So I'm truly blessed that we have this, and thank you, Nia, for including all of our communities, because as we move together in this journey, we have to make sure that all of us are represented. So it gives me great honor to introduce our two presenters today to share with us their stories. Our first presenter is Joe Enlet, who is an island boy. He is from the islands of Chuuk in the Federated States of Micronesia, where he was born and raised. He moved to the U.S., where he completed his graduate studies at Multnomah University in Portland, Oregon. He is a founding board member of COFA Alliance National Network and served as its former president. Can has been a champion for COFA Islander policy work and has successfully passed legislation in Oregon which provides health insurance access to COFA Islanders. Currently, Joe is Senior Health Policy Analyst and Community Liaison at Multnomah County Health Department, working on culturally specific health equity strategies for Public Health Department. In 2015, Joe was appointed Governor Brown of Oregon to serve as a member of the Oregon Health Insurance Marketplace Advisory Board. He is Policy Commissioner with the new Portlander Policy Commission for the City of Portland and serves as the chair of the commission. Joe is also a faith leader at his Chuukese church. Ladies and gentlemen, let's welcome Joe.
Raranim. Do the tongue roll and then say Raranim. All right, that's a good day in Chuukese. I want to say also tiro, my respect to all of you, especially to our elders who I I've learned so much from, and all of you. I, I want to thank the Laughing Samoans for emceeing our day today. And I'm here to tell you who the finalists are for Best Dancing from last night. So we have a few doctors who made the cut. But the award goes to the folks from Arkansas. So give a round of applause. Who knew that Arkansans, do you say that? Arkansans can party. But yeah, we saw them party last night. But thank you. I'm really, really honored and blessed to come here. I've learned so much from all the presentations. I've stolen so much from all the presentations. And I procrastinated. Sorry, Sheldon. And I gave my, well, I had to change a lot of things because I wanted to kind of also respond to some of the presentations here. And I will sound like a broken record to a lot of you. I will be speaking to the, singing to the choir on a lot of things. But I think it's a good place to kind of remind ourselves of some of the values that we hold dearly as Pacific Islanders, and hopefully I can share some thoughts and maybe have some ideas percolating. And so I asked Nia, can you send me something to do, like a facilitator position or something, so that I can justify to my work to, you know, pay for me coming to the conference? And she emails me back and says, okay, great, you're going to be a plenary speaker. So I was like, no, that's not what yeah, but that's Nia. So where's the presentation? Is that it? So I borrowed a term from our brother from Kushai, who said some blasphemous things yesterday about Kushai being God's favorite island, which we know is not true, because Chuuk is the favorite island. But he said Pacificizing, and I love that term. I know that there are other people who've used that term, but he used it here, so I wanted to give him credit for that. So I changed my title and I said, Pacificizing Health Advocacy and Policy Change. By no means am I an expert in this field. I'm fairly new in doing policy work, but I think it's the necessary step after we talk about the data and talk about the research. It has to translate into policy and systems change work. I also know that you know, a lot of you come here full, and you know, I don't believe in the banking model where I'm imparting to you knowledge that you don't have. I'm only kind of awakening the knowledge and the fullness that you bring to this conference. As Pacific Islanders, you have a lot to bring to the table. So my talk will be kind of eclectic, and it's also reflective of my thought process, which is circular and not linear. So if you feel like I'm going in circles, I am going in circles. So I just want to be really upfront with that. I live in Portland, Oregon, and that's a bulk of the things that we've done is really based in Oregon. And we've had some success, and I guess that's why I'm here to speak to you and talk to you about some of that success. But I think it's really important also to kind of step back and look and be very explicit about the values that drive the work that we do. I think we all come, you know, they say there's a myth of objectivity, because we all come with a lens, a certain lens, everybody from every culture. And specifically for Pacific Islanders, we come with a Pacific lens. And it's better to be upfront about it and be open about it. So I will say that I am biased when I speak about policy analysis or policy development and implementation. It is with a Pacific flavor. So what I will do is, first of all, just kind of uncover what those underlying beliefs and presuppositions are. And I think that will kind of give you an idea of where I'm coming from. So what are some of the underlying beliefs and presuppositions that have kind of informed the work, the policy work that we are doing in Portland, Oregon? First, we believe health disparities are the legacy of historical colonialism and imperialism. That is something that we believe. We also believe that health is determined, as the lectures before this presentation have said, as determined by social conditions, not just individual choices. Individual and institutional racism and discrimination are root causes, among other causes, of health disparities and social inequities, specifically when we're talking about disparities within people of color communities. Pacific Islanders, as all people of color, face higher rates of racial, economic, health, and educational disparities. And we believe that our voices are also absent from policy decisions that affect the overall health and social well-being of our communities. These are beliefs and presuppositions that we come in to the work with. We also borrowed from the World Health Organization definition of what health is, but we kind of added in another aspect. Health means a state of complete physical, mental, spiritual, and social well-being, not just the absence of disease or infirmity. We're very upfront about that it's about the whole person. And when we talk about health policy, it is within the framework of health equity. And we know that health equity, cannot be done in a vacuum. It considers historical trauma. It also talks about culturally specific disparities and particular experiences. The problem with talking about equity as a theory is that it becomes separated or disconnected from actual experiences. And if we want to do health equity work, it has to be tied to the specific experiences of particular communities and particular persons, because an equity model might work for a certain group of people, but not necessarily Pacific Islanders or Chuukese or Marshallese. So these are some of the things that we come in and we're explicit about. Some of our values. We Islanders are not means to policy ends or to research ends or to charity work ends. We are ends in ourselves. Often communities are used as a means to a certain goal or a certain end. It can happen in research, it can happen in policy, where we're used for the purpose of research. But it's not really for the goal of liberating or for improving the well-being of communities. Our island culture and values are assets, not deficits. They don't skew the data, as some researchers might say, but rather it enhances and gives meaning. So we really value highly our culture, and we try to the best of our ability to do policy work in a way that really speaks with and to and from our culture. And so we talk about pride in our cultures. And lastly, community voice and participation is essential in all research, policy work, and practice. Community voice, and often we have people who say they want to engage community, and I know we've run into the same mistakes and missteps about really, are we really engaging community? Are our agendas, our policies reflective of really what the community is saying, or is that more reflective of what we think the community is saying? So we're very serious about that when it comes to engaging community. There's also a phrase that we often hear about bringing community members to the table to have a conversation, to have a seat at the table. And as a person who likes to question things, I say, but whose table is it? You know, have we really thought about whose table are we being invited to? Because oftentimes it is us, the professionals, we have our tables, and then we invite community members to come to our table. I think we need to change the paradigm and say, well, where are the tables where people are sitting at? Can we ask to be invited to those tables and really meet people where they're at? Tana and I were talking about this. Sometimes when we engage community members and we have an idea about what we're wanting to do or wanting to get from community members, but if it doesn't come up in the conversation over coffee or anything, maybe it's not the right time, and be patient with that. So at a conference last week in DC, I said one of the strategies that we needed to have in working with our communities to do policy work was patience. There needs to be emphasis on how we are with the other person or the community and how we are internally being changed. Because I think a lot of things that we do can really just exist on a surface level in a rational realm. But if it doesn't change the person that we are, then can we really say that we're engaging with the other person? So these are kind of some of the underlying beliefs and presuppositions that we have. So when we do policy work, there's so many models out there about policy work, but I'm just going to talk about the policy work that we're doing in Oregon, Portland. So we talk about output versus impact. And I think the research and some evaluation people probably talk about this. I borrowed this from our partners who are doing evaluation work for us. So when they talk about output and versus impact, it means that our work must not be content with measuring what we do, the output. So how many people did you see? How many people, came to this event? How many events did you do? Kind of like the quantitative stuff. But rather, we must ask the deeper questions about impact. The deeper questions: how is it really impacting people? How are those policies impacting people? Are we asking the questions about what are the unintended consequences of a certain policy? We don't just ask, is it politically feasible, this policy, but we also ask, is it culturally appropriate to a certain community? So the presupposition here is that people are more than just their physical selves, nor are they the sum of their outward behaviors. And also, people are more than their rational beliefs. And I think Dr. Samo, I think, was talking about, often we say education, about health education, where we're providing information. and people can have that information as in their minds, but it doesn't necessarily translate into corresponding behavior, because people are not always driven by what they know. We can know that pizza has a lot of fat in it, but there's that island motivation inside that says, oh, we got a party tonight, so we'll still eat pizza. We try to ask deeper questions, not just questions about how many people it affects, but also their cultural values. And I want to quote, I think it's his name is Patty Mills. He wrote Getting to What Matters. And he said, institutions grow in the direction of their persistent inquiry. And really, it's about being intentional about the questions we are asking, and not being content about asking just the very surface questions, getting back to output and impact, are really asking those questions. Are people being changed about the way they think of themselves? Or are we just saying, do people have the information? So we're getting at something almost the same, but in different, from a different framework. I think that going into policy work, we have to be asking those questions about our policies and being stubbornly patient with the process. In the Western world of being industrious, and you got to do things, and you got to get things done. There's value there too, but oftentimes we miss the deeper questions that we can get to only by spending time. And in our island cultures, I will say in Chuk, if you observe people building one of those huts, we call them ut, or people will work for 10 minutes and they will sit and chat for 20 minutes and hey, what's up? They will talk and talk and talk. And then you'll get a little bit done today. And then the next day, repeat the process. And if a person, from the Western culture will see that, they're like, oh man, they're so lazy. What's going on? You could have built this hut in 2 days. It's taken 2 months to build this. Because in the culture, finishing the hut is not the main goal. It's the process. It's a process of sitting together with people. There is things that you learn about working together, cooperation. You learn about what's going on in your families, and it brings people closer together. So the product, may be great, but the deeper things that happen only in process is of value. So what am I trying to do here? I'm calling for a robust collaboration between research, policy, and practice, and yet being very explicit about our underlying values. What are those things that we value? How do we want our work to impact people? And are we content with it just having impact on the surface, or do we really want to take time so that research is done with community, and policy is being done with community, and it gets to really not just get people health insurance, but are people becoming their whole selves? Are people actualizing themselves? Are people really being heard? Are they treated as human beings? There are deeper questions that we need to be asking if we want really our work to matter. And same in practice. So, and I borrowed a lot of these concepts. I borrowed from different sources, but in the Pacific Islands, you don't really do give credit there and give credit. We just, because it's all ours, right? We just share it. So I'm sharing. That's what I'm doing. So, and yet the nucleus here, what ties all of this together is community. And if there's real collaboration before the research starts, or the research questions are even formulated, before it's formulated, it is in conversation with community members. Are the community members asking these questions? Are they being part of the process? Are they also the researchers? And the conference last year, we were talking about that we need to have our people be part of the research. And then there's a policy as well. Are people informing the policy making? I think somebody said yesterday that our people can do this. They shouldn't just be the ones, being the subjects of the study, but we can also invest in building the capacity of community members to do the analysis, to be the ones that actually interpret the data, not just the ones who receive the interpretation of the data from the professional, but actually the ones who are saying, no, actually, this is what that is showing me. And same with policy work, and then translating that into practice. Now, if there's real collaboration, then researchers and policymakers are sitting together at the table while we are going through those questions. Because then the research has a set goal, and policymakers are making policies based on real evidence, based on what we together formulate with community, and then translate that into practice as well. And I wonder, is there really collaboration? Are we really, and because I know that we're working in silos a lot of the times, and I know there are attempts to do this, but since we're here in this conference, I'm also I'm challenging us too, researchers and policy people to come together, because I will tell you that a lot of policies are policy work is being done, but it's not based on real data, and data that actually matters and is credible. So anyways, I know I'm running out of time. So I just want to talk about how we did that in Oregon. And it's not a perfect model, but this is, so I talk about COFA, right? And that's Micronesia. And I know many of you already know these are the countries that are included in COFA, or the Compact of Free Association: Palau, the Federated States of Micronesia, and the Marshall Islands. We know the colonial history. We're under Spain, and then Germany, and then Japan, and then the U.S. And then the compacts were established in the 80s, late 80s, different year for Palau from the Marshall Islands and the FSM. And this is a very simplified description. Treaty that gives the U.S. full military control and denial rights in perpetuity. So that means just forever. They have full military power over the islands. And it also, at the same time, gives COFA Islanders legal right to live and work in the U.S. However, that last bullet says riddled with broken promises. And I think you can understand what that means. And we believe that the U.S. has not lived up to the promises of the Compact of Free Association. Even the creation of the compact was kind of biased as well, as some people will say. But anyways, that's not the focus of my presentation. That's just what is. So with that, a lot of changes in Micronesia. I don't have to go through everything. Cultural changes, economic, health, social. I want to say I love what Dr. Cuarte said in one of the breakout sessions yesterday about maybe the worst thing that actually happened to our islands was when we got aid from the U.S. in terms of money being poured into our islands. So I just wanted to echo that. A lot of religious changes, and also we heard about migration, right, all the way out to the U.S., and it's really sped up in the last 5-10 years. We also know about bomb testings in the Marshall Islands, 67 nuclear bomb tests over there, equivalent to 7,000 times the force of the Hiroshima bomb in the Marshall Islands, and a lot of the fallout and the immediate long-term effects from that. So here's, and those were obviously policy decisions that were made by the federal government. Here's another policy that has really been a barrier for COFA citizens. In 1996, the Welfare Reform Act made COFA Islanders categorically ineligible for Medicaid and almost all federal safety net programs, the programs that we pay taxes into. And these programs include Medicaid, food stamps, TANF, even federal student loans. I like to tag on that one, federal student loans as well, because I really wanted to get federal student loans, but I could not because I'm a COFA citizen. So because of that, the COFA Alliance National Network in Oregon organized itself and said we're going to advocate and do policy work to make things better for COFA citizens. And we came together at a Denny's restaurant. So if you want to do advocacy policy work, go to Denny's. Are there Denny's in Hawaii? Okay, good. All right. Does it have spam? All right, so this is a summary of what we've been able to accomplish. 3, 4, 5, 6 bills that were passed. Driver's license bill, making it so that COFA citizens can have the regular 7 years, 8 years driver's license. And then there was a premium assistance program study. There was a resolution. All of these pieces of legislation. This is, again, I'm just saying output, stuff we did. But it has really impacted the lives of our citizens, of our islanders, in many ways. And how did we do this? We wanted to do it the island way. We said we're going to reach out to people, and our strategy is going to be, we're going to tell the story. And we know in U.S. politics, it's partisan, right? You have Republican, you have Democrat. Usually Democrats are, friendlier to extend services to our communities. But we said, in order to be really effective, we have to reach out to the other side. So what we did was we went and told our stories to the Republicans. And guess what? Most of our bills have been chief sponsored by Republicans. It is the Republicans who have stood up in the legislature and fought for us. And all the Democrats are like, whoo, yeah, more power to you. Because we wanted to really be about the people and not be about, by partisan and party lines. And it's amazing. All 6 bills have passed in the legislature without a single negative vote. Not a single one. And this is from 2012 to 2017, which is a remarkable feat. Even in the committees, it was all just, everybody just voted yes for it. And it's because we brought our community down to the legislature. And when I mean bringing down the community, I mean our communities came down from the eldest to the youngest. The kids, we would give them a fact sheet and then give them cupcakes with the word COFA on it, and they would literally go to every single senator and representative office and give them cupcakes and give them the fact sheet. And we brought our community members there. We trained our community members to speak to representatives and senators. It's a long process, but you know what? We were able to do this because of the will and wisdom and power of the community. We had when the resolution was read in the House, we had one of our eldest, community members standing down there with the legislators, and they were talking about our community. So we had our community come down. We sang songs during the opening of session. Our brothers and sisters from the Marsh Islands, they came out and they sang songs there. And it wasn't just about the bill. It was more about, hey, let's keep building this relationship with these legislators, these policymakers. And I will tell you, when we first got to the legislature years ago, we said COFA, and we saw this big question mark on their faces. Not a single person, maybe one person knew about COFA. And today I can tell you that every single person in the legislature in Oregon, if you say COFA, they know exactly what you're talking about, because we told the story. And one example I give is I was walking downtown at a mall, downtown Portland, and I looked up on this escalator, and this guy was coming down. He was the senator who was the leader of the Republican Party. So he comes down, and I say, "Oh, Senator Ferrioli." I come up and greet him, and he looks at me and he says, "Oh, COFA." And I didn't know if I was going to be offended but I said, "But it's all good. Yeah, I can put that as my middle name." But yes, the power of telling story and mobilizing the community. It wasn't us. It wasn't the lobbyists or because we were really good and savvy. No, it was because the community came out and told the story. And when we visited the legislators, we did not go to, well, we did go to some of the offices, but we brought the community to the community room. And then when we scheduled with the staffers, we asked them to bring the legislator to the community room. And so when they came in, we gave them the whole island shebang. We gave them leis, we fed them, we sang songs, and we didn't know their names. We met them for the first time, but they felt like family. And they came in and we told our story again and again. And whoever was willing to listen, labor unions, state government agencies, police departments, anybody, we would tell the story. And we had so much support, people coming in to testify who we did not even talk to. They just heard about it. They read it in the paper. They had some interest in helping COFA communities, and they came out. I'm not going to go into all the stuff about the bills. We can talk about that later. But yeah, talking story, mobilizing communities and churches, and we also partnered and collaborated and sat down with the people there who were doing this work already. We learned from what they were doing. It's just another list of the people we engaged with. And I already talked about this. Oh yeah, community events and parties. We've had legislators who've come out and joined us in parties. They've come to GEMEMs. GEMEMs are huge parties in the Marshallese community. They're birthday parties, but they look more like the whole island party. And we had people from the legislature come out and be with us. Yeah, this is just another list of people that we reached out to. But you get the point, right? And in all of this, we wanted to make it really about story, really about connecting with people. We stayed true to Pacific Islander relational model, person to person, face-to-face interaction, knowing people by name. And we can say that, but sometimes when we need things done, then we just overlook some of these things, which I think are actually key to why we've been successful there. And we have a lot of food too. And but you know what? People can still know if you're just bringing food just to bring the food and have them there, but they will know if they're really welcome or not welcome. You know, it's not just about bring the food and then you're culturally competent. No, if people don't feel the impact of how you relate to them, well, they'll eat the food, but you know, you won't see them anymore. So this quote we often say is, and this was in one of the interviews from some of the media. They talked about, oh, you're so successful. You're happy, right? You're happy now that you have health access. And we've said, yes, we're happy that we now have access to health care. But the biggest win for us is that now for the first time we were heard. And that's impact. People said that for the first time, we feel like we are human. So, in any line of work we're doing, are we really asking the deeper questions? Are we really doing research that impacts people's lives in a very particular and personal way? Are we doing policy work that really impacts lives? Are we as practitioners, clinicians, working to really impact lives? I want to uplift my brother, Dr. Sheldon, when he said that, when his community members come in to see a doctor and they see him, and that relief, that you can't measure that, put it on paper, but you can feel it, and that's what we're talking about. We want to get there. So thank you so much. I'm sorry for going in circles, but thank you.
Thank you, and I think that's a common theme we're all gathered here for is for all of our communities, so that we can make sure we are heard together. So I would encourage us to not only, I know we have our island prides, but let's sail in the same canoe, get to know each other so that we can continue to advocate for each other. So thank you very much, Joe. If we can give another round of applause. Our next presenter, I've had the pleasure of meeting in D.C. at this convening, and as Pacific Islanders, it's always good to see folks from our own looks and features, but at times of scarce resources, we also have to look at folks who are believers and lovers of our communities. And I could truly say that not only just the expertise that he brings, but the authenticity of truly, like Joe said, feeling for the community. And that is our next presenter. Ben D'Avanzo is the Senior Policy Analyst at the Asian Pacific Islander American Health Forum, a national health justice organization which influences policy, mobilizes communities, and strengthens programs and organizations to improve health of Asian Americans, Native Hawaiians, and Pacific Islander. In this role, he develops strategic health and equity guidance for policymakers and health forum partners. Before coming to the Health Forum, Ben worked at Families USA, a leading consumer health advocacy organization. Ladies and gentlemen, let's welcome our brother from D.C., Mr. Ben D'Avanzo.
Hi, thank you. Let me just get my presentation up. And excellent. So thanks again, and it's a lot to be following Joe's great presentation, especially because Joe is one of our board members and therefore my ultimate boss, and will be, I'm sure, reporting back and telling them how great a job I'm going to do, right, Joe? Thanks for having me at this gathering where we've had such great speakers. So following Joe and all the other speakers is really wonderful, having those opportunities to learn a lot. I will be speaking about COFA Medicaid from the federal perspective. The Health Forum, we work out of Washington, D.C. Our headquarters is in Oakland, but a lot of our work focuses on the federal work that's going on in D.C. And I just really want to emphasize that when we talk about Pacific Islander, Native Hawaiian, as well as Asian American health at the Health Forum, we really, as Joe really talked about, make sure that our analysis, our information, the stories we're sharing, the ways we're talking about these issues are really informed by the communities that are most impacted. And we really see our job as, empowering those communities to have the tools that they need, that many of you need, in order to make the change that will get to the personal or community goals that are desired. And so this is kind of the goal of my presentation. And I'm hoping that at the end of it, you all will be able to think about the steps that you can take, both around COFA Medicaid, but around broader federal health policy in general. And so I will forewarn you that my presentation, since it is about DC, is not going to be as positive, perhaps, as Joe's was, but I will try and end on a uplifting note. Going through the current efforts to restore COFA Medicaid, a new threat to COFA health, and then some opportunities that I think we have. So just let me get to the next slide here. Is it this thing? No, it's not working. The arrow. This one? Oh, there's a keyboard down here. That's helpful. I will get this to work eventually. Arrow's not working. I'm not bad at computers.
Okay. You can arrow up, arrow down.
All right. If I go like this.
It show up there.
No, it's not showing up on there. Right?
The AV up. Did we pull it up right here?
Yeah, this is it.
Commercial break.
Yeah. You can all just think about yourselves as
There you go.
advocates and meditate on
Go
that.
from there, from beginning.
Yeah,
and click.
that's what I did.
Oh.
But it's not, I decided that it wants to get stuck on this page. Just unusual. Maybe if I don't want to close out of it because then it'll... Yeah, so this is a symbol, everyone.
Of DC.
Try to exit the other ones.
Oh, somebody that may be able to help.
Yes. Are we having someone coming who might be able to help with
Try from the beginning again.
Yeah, it just doesn't seem to be connected anymore. All right, I'm just going to start talking, and then hopefully someone will be able to help figure this out. So COFA, right now we've had a series of bills introduced for the past decade or so, a little more than a decade. We've had now 23 pieces of legislation introduced in Congress to restore access to Medicaid for COFA. As Joe pointed out, that was taken away for the first time in 1996. Many of you know that deep impact that has had on communities. So the legislation that was introduced just a couple of months ago for this current Congress, because every time a new Congress starts, every 2 years, you need to reintroduce legislation, and it's a time to update and talk about it. So Senator Hirono from Hawaii has introduced this bill, as well as Representative Hanabusa, also from Hawaii, and it's the Covering Our Fast Allies Act, or the COFA Act. So this is a piece of legislation, and basically all it does is undo the damage that was done in 1996. We have co-sponsors. Co-sponsors in Congress means that these are people who are visibly supporting it. These are our champions. So in addition to Senator Hirono in the Senate, we have Senator Schatz, also from Hawaii. And really exciting for us this year is, no, this is the other one. Although it's showing. No, it's not mine.
That's not yours
No.
either.
Oh, wait, that one, yes, this one's mine. Okay. Oh.
Okay, so you just hit this.
Okay, awesome. Hey, so this is the bill, and these are the list of co-sponsors. So I was saying that Senator Murray from Washington is a new co-sponsor this year. She is a big health leader in the Senate, and so it's very important that she joined the bill. It's a big symbolic win, and I know those of you from Washington maybe have been involved with that, which is great and fantastic. And then we have a bunch of co-sponsors in the House, but not as many as we would like to see. So if your representative is on there, or someone you might have a relationship with is on there, advocacy for getting more co-sponsors is really important. So we also have over 120 endorsing organizations, which is another win, because we have a lot of broad organizations, not just either API organizations, Asian Pacific Island organizations, but we have healthcare organizations, we have unions, we have immigrant rights organizations. And so something I've really noticed engaging in health advocacy over the past few years is that knowledge around COFA Medicaid is really spreading. It's not just a narrow issue, and a lot of people are learning about the injustice that was done and are supporting it. And that's really important for providing us a base for making that change. I also wanted to highlight a couple other key pieces of legislation that will restore access to COFA Medicaid. So the Health Equity and Accountability Act is a really important piece of legislation. For me personally, I've worked on it for a number of years. It's the only bill in Congress that is a comprehensive view of health equity. It's endorsed by the Congressional Black Caucus, the Congressional Hispanic Caucus, and the Congressional Asian Pacific American Caucus, CAPAC, which is taking charge of it this year, along with us at the Health Forum. That's a piece of legislation we are working on right now. It's basically a compilation of every idea someone might have about how to introduce health equity. It's hundreds of pages long. It's basically a tool for advocates, so we want people in the states to look at this piece of legislation for how ideas might be to move forward health equity. And so COFA Medicaid restoration is in that bill. That'll be introduced probably in May. And then the Health Equity and Access under the Law for Immigrant Women and Children and Families Act, the HEAL Act, is another immigrant women-focused act that, among a few other things, includes COFA Medicaid restoration. And those bills have actually a pretty wide array of co-sponsors, and so while not every member of Congress has endorsed the original COFA bill, they actually have endorsed that policy, and it's something that we want to highlight. But we need to talk about the world that we live in, right? So this is who runs Congress today. It may not be who we want to run Congress today, right? But it's the reality that that it is a Republican-run Congress, both in the Senate and the House. And while the Health Forum is absolutely a nonpartisan organization, and we appreciate bipartisan work, the Republican majority has made cutting health care a priority for them, which is not something that the Health Forum supports. And so we just need to talk about the fact that in the current environment, expanding access to Medicaid is not something that's going to be moving forward. And I really want to address, so when we talk about COFA Medicaid, we talk about an injustice and restoring something that was taken away and, undoing something. When we talk to Republicans, unfortunately, they don't see it that way. They see it as expanding something new, even though it's not. And that's a challenge we face because right now in the current political environment, Republicans simply cannot talk about expanding new healthcare opportunities. They're actually trying to go in the opposite direction, as we all know. And I think that's really important to acknowledge and talk about. And we need to shift that narrative and help Republicans and conservatives and everyone really understand that COFA Medicaid is not an issue of something new. It's restoring something that was taken away, but it's a challenge that we face. And it's especially important because, as you can see in this list of members of Congress with the top 15 COFA populations, these are about half of Republicans, a little bit less, because Jason Chaffetz from Utah resigned, but it was about 50-50 for these top 15 districts that are Republicans. So as those of you know, a lot of Republicans do represent a lot of COFA populations. And as Joe said, people might not know who COFA is, but if you educate them and you share those stories and bring in people who are impacted by these policies, there's a lot that can be done to educate. And we have seen some of these Republicans on this list quietly tell us that they support this policy, even if they can't publicly get on board with it. So let's talk about who our healthcare leaders are. These are the people who are making the decisions. Again, are these the people we would ideally want? I don't know. But just starting with where we start in the upper left-hand corner in the White House, President Trump. He is the one who, I guess, calls the shots, right? Then going with the Secretary of HHS, well, actually, needed to update that. Secretary Price resigned last Friday since I first designed this presentation. We don't know who the new secretary will be. There's a lot of rumors. It could take a month to find out. So that's something we'll be watching for, because the HHS secretary runs the day-to-day operations of the broad healthcare infrastructure of the country. And then Seema Verma is the director of the Center for Medicare and Medicaid Services. This is perhaps the most important agency, federal agency, when it comes to healthcare access. This is the agency that does all of Medicaid, Medicare, Affordable Care Act, all the day-to-day decisions. So when you hear about Medicare, Affordable Care Act in the news, that's Seema Verma. Congressional leaders, Speaker Paul Ryan, Majority Leader in the Senate, Mitch McConnell, these are the people who set the strategy in Congress. If something is going to happen, either one of those chambers, nothing's going to happen without them wanting it. But when it comes to healthcare, the congressional committees, the way that Congress works, right, is that you have committees with jurisdiction over different issues. And these are the gentlemen who are in charge of healthcare policy for Republicans. So that's Kevin Brady in the House Ways and Means Committee from left to right, Greg Walden, Lamar Alexander, and Orrin Hatch. So these are the people who decide if a piece of healthcare legislation is going to be moving forward. These are the people we have to decide and convince. So it's really important to see their faces. You might see them in the news. And their role is basically to be the decision makers around healthcare. And this is why we talk about them. So that's COFA Medicaid. Unfortunately, I want to talk about something that we've seen in the last few months that actually might take us back further. So as you all know, and may have seen in the news likely, Congress has been trying to repeal the Affordable Care Act since January. It's not succeeded, which is a great victory. But in those bills, something that has not been talked about enough is that they would have specifically targeted the COFA people and taken away health care from them. How did they do that? So as we know, in 1996, the definition of someone who is eligible for Medicaid was changed to a qualified immigrant. And in the bill that passed the House of Representatives that would have repealed the Affordable Care Act, it actually would have changed eligibility. So that bill would have cut the amount of health care tax credits available to a very small amount, but it still would have existed. But for people who are COFA, who are not qualified immigrants, they would not have been able to access those tax credits. And that is a big step backwards from today, where at least COFA people can access tax credits. Even worse, in the Senate bill, that bill would have not just only denied access to tax credits to COFA people, it would have entirely blocked them from accessing the marketplaces with their own money. Essentially, it would have treated COFA people as undocumented. And we really need to be aware that even though healthcare repeal is not moving forward right now, as long as Congress is controlled by people who want to take away healthcare, this is going to continue to be a threat and something that we need to speak out on, not just restoring access to Medicaid, but making sure that we do not lose progress. And this is something we're very afraid of. Luckily, we did see some folks who might not ordinarily have spoken out about COFA populations speak out about it, thanks to the ongoing education we've been doing. But it's something that we need to get a lot of awareness around and talk about the stories of people who are COFA who did access the Affordable Care Act marketplaces. I do want to turn to something positive now. So there is an opportunity that we are currently seeing to update the way that the federal government collects race and ethnicity standards. This is determined by the Office of Management and Budget, which is an agency of the federal government basically connected to the White House. And it decides how all federal agencies, education, healthcare, housing, when they collect data, these are the questions that they must ask about race. These standards were last updated in 1997, and that was when Asian and Pacific Islander and Native Hawaiian were separated into two categories, which is progress, but as we know, not progress enough. So over the past year at the Health Forum and other partners, many of you perhaps in the audience have engaged in this, we've been fighting to tell the Office of Management and Budget, as they are looking to update these standards ahead of the 2020 census, that you must require the collection of disaggregated data. Because as we talked a lot about this conference, we can't do research, we can't do advocacy, we can't change practice unless we have the data. And this is the first step. And so as you can see in the slide, this is what we've decided to ask for, this new standard where you not just ask in a federal survey about Native Hawaiian or other Pacific Islander, and I will say that we also want to strike the other in that. We want to ask if someone is Native Hawaiian, Samoan, Chamorro, Tongan, the top 6 categories by population, as well as write-in with the next 3 as examples. And this should give us much better data, not just of the federal government, but state and local governments often use these standards as their own, and we really want to advocate for that. So we will find out in December when OMB issues its decision whether it's successful. But we had over 3,000, I think around 3,500 comments submitted to OMB through this campaign. And for a regulatory campaign, that is a lot of comments. And I think that really showed, and we actually heard from the agency that they were really impressed by that because it really showed how much people want to see themselves represented in these federal data collections. And so that was a really hopeful step for us, and not just the negative things that we're doing on a day-to-day basis. So I just want to kind of start by concluding that voices matter, right? So as I mentioned, they've been trying to repeal the Affordable Care Act for 9 months. And a lot of the reason that they've failed, despite everyone's expectation that this was going to be gone on by February, is because of the voices of people who are impacted. We've seen people in wheelchairs getting arrested in the halls of Congress. We've seen town halls getting flooded that were never attended by a dozen people, let alone hundreds of people. And this is all amazing. And it's been widely credited with the reason that Congress has not been able to repeal the Affordable Care Act and cut Medicaid. And so it's really important that the people who are most impacted by a policy are the ones who are shown on the TV screens in the media stories. So while we, in DC can, provide advice or talk to, members of Congress or whatever, these are the most important things. And these are how things get done. And so for COFA Medicaid, these might be some familiar faces from actually our recent lobby day, and these were some folks on the Hill who were talking to members of Congress about COFA Medicaid and had some great and not so great experiences, but it's really having folks from communities or representing communities or who work with communities share their stories, their data, with members of Congress on the Hill or with their local staff in their district offices. You don't have to come to Washington, D.C., making phone calls and talking about COFA Medicaid until you end up at a mall and your member of Congress says, oh, you're COFA, right? And so just kind of wrapping back up to where I started, the stories and the experiences of the people who are most impacted are the most important parts of this to us at the Health Forum. And I really want to emphasize that our goal is to provide this sort of information and talk to you about what's going on in DC in order to provide you the tools so you can be like this and talk to your representatives about the importance of COFA Medicaid, why COFA people should not have Affordable Care Act tax credits taken away, and why disaggregated data is really important. So I will leave it there with my contact information. Feel free to reach out.
Let's give a nice round of applause again to our presenters. Okay, So the president said only 2 questions today. But as you've seen, we have presentations from some of the wonderful work happening at the local level, and then also, the other perspective of some of the work that still needs to be done at the federal level. And I hope that if there's anything to take today, is for our communities to continue to move forward, be brave, change the shorts to some slacks and do the legislative visits. It's all important at many levels, whether it's local or federal. But I'll go ahead and take 2 questions at this point. And where's our mics? Our mic's right here, so please wave your hand nice and high. We have right here on the right side. And it looks like we have 2 on this side, so. Our speakers will also continue to be here throughout the day, so we can, if we don't get your question, we can definitely track them down.
Aloha. Mahalo for your presentation. I was just wondering, do these, the passage of these bills set precedents for all people affected by COFA, or do they set precedents just for the community that, like, let's say in Portland, Oregon, has worked hard to put together the legislation?
Which bills? Sorry.
You were saying that 26 bills or something like that passed.
Mhm.
Do they affect everyone who
Yes.
is within COFA? So you can keep building on the precedences even though you come from different communities?
Absolutely. So the bills that were introduced this year and have been introduced in the past few years, but this year by Representative Hanabusa and Senator Hirono, would restore access to COFA people, COFA citizens, Medicaid across the country, and actually would mean that states like Oregon wouldn't have to worry about providing the solutions for their own people because we'd have a nationwide restoration.
Okay, great. Mahalo.
Michael Levin. I'm wondering if you have any idea how many COFA participants there actually are and how many you expect to see affected by the law, because I don't think there are numbers. There were previously periodic surveys of Micronesian migrants to Hawaii, Guam, and Saipan. That's required by the compact, the impact of the compact, but nothing for the mainland, which is one area where you might want to do some looking towards getting those included when they do surveys. And then the current survey in 2018 is not going to cover anything on health. The ones that Interior is funding at $1.5 million to do Hawaii, Guam, and Saipan, and you're not going to get kind of information, and it seems like this would be a group that could look towards trying to get accounting of at least how many COFA people there are in Hawaii and Guam, if not major areas of the Pacific, of the mainland. So my question is if you have any idea of how many people are affected by this. Thank you.
Do you want to start with Oregon?
Well, we can give, I think we can give. In Oregon, I'll have Ben talk about the national efforts, but in Oregon, we don't have the numbers. We don't have the data. It's been estimates from the community, and we've shared that with the lawmakers, but you're right, that's a huge need, and that's one of the biggest challenges that we've had is they ask us what the numbers were. Our estimate is that there are about 10,000 COFA Islanders in Oregon, and we knew that was the question that people were going to ask. Let me just say this, the reason why the Premium Assistance Program really passed was not so much because they were looking for for data. We all know the policymakers, the bottom line for them is the money, right? So we looked at the economic argument for it, and the way we did it was we didn't want to be the ones that said it, so we asked the agency that oversees the marketplace in Oregon to actually do the study. And we did that by so there was a bill before the bill And that bill was to ask the state agency to crunch the numbers to see if we were going to create this program for 1,500 COFA islanders, how much would it cost, and is it economically viable? And so they came up with the recommendations. It's a legitimate study by the state itself. And they came out with the numbers, and they saw that actually, for every dollar that they spend on the COFA Premium Assistance Program, the state would bring in $9 from the federal government through the advanced premium tax credits. And that was the data they were sold on. It wasn't really the health disparities or data of how many people there were there. They wanted to know how much it costs. And so we were lucky enough for them to agree to do the recommendations, and their recommendations, the report saw that was the return on the investment. So that's kind of the key to why that passed. But data continues to be the issue.
Yeah, I'll just add the latest data we have really is from a 2011 government report. So that's 6 years outdated at this point, that said there were 56,000 COFA people. I think there was even feedback at that point that felt like an undercount to a lot of people. And at this point, it certainly is an undercount considering how things have changed. So actually, sometimes we will talk about that with policymakers, but when we talk with folks who know the true realities on the ground, those numbers that we have don't reflect what they're seeing. And of course, more data is a really important goal for us, and better quality data.
Okay. Thank you. And if we can give another round of applause to our panelists here. So we have, again, as always, during our break, we have our cultural sharing. And at this point, I'd like to bring up our Micronesian sharing for today.